The natural history of transposition with intact septum involves involution of the left ventricle, such that for most patients, by the time they are about 2 to 3 weeks old, the left ventricle has lost its ability to acutely support the systemic circulation. And so in many centers, the ideal operation is the arterial switch before this sets in. But for patients who present later than this age, what is advocated is a 2-stage arterial switch involving a preliminary LV training, and Dr. Brizard just showed us how they do theirs. Some people also recommend the atrial level repair. This presentation, I'm using 5 patients, the outcome of 5 patients that we've operated on, all of them who were older than 4 weeks old, to examine whether the age limit can be extended for this operation. The first patient was born at term, 4 kilos, was cynosed with transposition and intact septum. He had an atrial septostomy within the first week of life, which proved inadequate, and so he was put on Prostin. But shortly after that, the patient developed respiratory distress syndrome. He had RV failure, renal failure. He was deemed too ill for an operation, and so the arterial switch operation was denied until the mother asked for a second opinion, leading to the transfer of the patient to this hospital. The child arrived here in a low output state. He was acidotic. An echo done showed the child had a TGA intact septum. He had severe RV dysfunction. The ductus was small. He had a very small ASD. And here I'll kindly ask Kenny to show us the echo for this patient. This was a pre-op.
Starting off with the long axis parasternal view, and you're going to see the compressed left ventricle slit-like here, intact IV septum, quite hypertrophied but dilated right ventricle anteriorly. There was some flow turbulence across, but it was a dynamic flow disturbance. That's just to show the 2 great vessels parallel to one another. And that's your short axis view that we saw just now, the 2 arteries in an AP relationship, and your 4-chamber view showing you the slit-like LV, your restrictive ASD or PFO there. And again, it's showing you the slit-like LV with an intact IV septum. There was no significant outflow tract obstruction. It was deemed to be a dynamic flow disturbance.
So the kid arrived on Saturday night. He was 53 days old at the time. He was resuscitated from his acidosis and low output state. He underwent the arterial switch operation. The ASD was closed. The PDA was transected. But he failed. He couldn't be separated from bypass, and so ECMO was instituted. But this was no longer necessary after 60 hours. Child made an excellent progress post-op with recovery of RV function. And this is the post-op echo. I think Kenny will have to help us again with it.
The LV, RV anteriorly, then your mitral valve. This echo was done late last year. In fact, January last year. An echo done in November is very similar. That shows a bit of mild RPA stenosis. And a 4-chamber view showing you a normal heart. Normal LV function.
The second patient was a late referral. He was aged 66 days, weighed 3.6 kilos. His echo showed TGA intact septum, essentially intact septum. There was a small VSD, just 1 to 2 millimeters. A restrictive ASD was present with a small ductus. He also underwent the arterial switch operation at 66 days old, had closure of the ASD, and then a stitch closure of the VSD. Just 1 stitch was necessary to close the VSD. The ductus was transected. We had LVAD on standby because the kid was 66 days old. Fortunately, this was not required. He made an excellent hemodynamic course post-op, but had a few GIT problems. He had septic ileus, which gradually resolved, and the kid was discharged well. He was seen here for follow-up in the 8th post-operative week. Was assessed, was doing quite well. But then we heard subsequently that the child had died suddenly and unexpectedly at home of undetermined causes. The third patient is a baby Zuma, baby Z, I should say. I think you are jumping to conclusions here. He was was born 4.5 kilos at term, TGA intact septum. He had a large ductus and a restrictive ASD. An arterial switch was planned, but the kid developed NEC and then developed bowel perforation. And so a septostomy was done. He had a bowel resection on 2 occasions, but survived to 31 days old and then presented for the arterial switch at that age. So at age 31, he had a switch with closure of the PDA and ASD and had an excellent result, was discharged home, and his kid is doing quite well. Was last seen 2010 January and is quite well up to now. The 4th patient, 55 days old, 2.6 Ks at the time of surgery. TGA intact septum, he had a small PDA, an atrial septostomy had been done. The kid was born preterm, the weight of 1.5 kilos, and so surgery was delayed to allow for somatic growth. But we suspect the LV pressure was low all the time. So he had a switch at age 55 days. At that time, he was 2.6 kilos. He had a switch with closure of the ASD and a PDA. Couldn't be separated from bypass and had an ECMO put on. 72 hours after the ECMO, the kid developed hemolysis with hemoglobinuria, which progressed on to renal failure. Peritoneal dialysis was instituted. The ECMO was converted to LVAD in an attempt to stem the hemolysis, but this didn't really work until the ECMO was removed on the same day. Kid struggled quite a bit afterwards. He had several wound problems. The heart was a bit enlarged. We couldn't close the chest for several days. A retractor was left in place for 2 days, which device we later called the Bloemfontein RVAD. I'm sure Dr. Brink can tell us more about that. The wound was finally closed on the 36th post-op day. Child was discharged from the ICU after 47 days. Last follow-up was February this year. Child is well, weighs 5.6 kilos. The last patient, also 55 days, 4 kilograms, admitted moribund with TGA intact septum, had a large ductus and a failed septostomy, had been transferred from an outside hospital, ventilated, but with severe cyanosis, had an urgent op, a switch, same procedure as the others at 55 days old, also had an excellent post-op result. This slide is just to give you a summary of the 5 patients. You can see the age range of the patients between 31 and 66 days old. The ASD we looked at as either moderate, as small, moderate, or large, 1+ being small, 3+ being large. The PDA 1+ refers to a PDA of approximately 2 millimeters or less. A 2+ between 3 and 5 millimeters. A 3+ is more than 5 millimeters. The LV pressure, this just gives a rough estimate. If you remember the first echo that was shown, an LV like that, we suspect the LV pressure is quite low, and so we'll put that at 1+. So this is actually an indication of the LV geometry. 2+ is more or less the septum being somewhere in the midline. If you have a normal configuration, we think your LV pressure is probably systemic, and that we classified as 3+. 2 patients were put on ECMO for 60 hours and 72 hours. And you would see here that the patients who had the ECMO were those who had the very low LV pressure, as according to our estimation. Now, the question to ask is this a widely applicable strategy? This is only 5 patients over a short period of time. And when really is the switch operation late? Based on this experience, we believe that with mechanical circulatory support, this 3-week age limit may be extended to 8 weeks and probably beyond without prior LV training. And we also note here that patients with large ductus tend to do better following late primary switch operation. I think that's the last slide. Thank you.